is a malignancy of the bone marrow cells. It has uncontrolled production of immature white blood cells called the blast cells. With this, it can cause an overcrowding of those blast cells in the blood, and it can crowd out good cells like RBCs, which with the fewer RBC production or circulating RBCs, patients are more likely going to be very anemic. Also, it will crowd out platelets, which more than likely will cause thrombocytopenia and bleeding. And it will crowd out mature white blood cells, causing leukemia in the patient at high risk for infections. So these blast cells, like I said, was very immature white blood cells. With these immature white blood cells, they're useless against body's defense of infection. So they're very non-functional cells. Mostly patients who go untreated usually die from one of two or both things, and it's infection and hemorrhage. We remember there's 5,000 to 10,000 normal white blood cells in your body. The experts don't know of one cause or a direct cause for leukemia, but they do know that there are many risk factors for leukemia, such as ionizing radiation. So if someone is exposed to radiation on and on, or one big event like an atomic bomb or a nuclear plant accident can cause them to be at high risk for some leukemia illnesses. Drugs and chemicals. If someone who had chemo drugs or radiation from the past cancers in their past can be at very high risk to develop leukemias later on in life. They say that patients who work in petroleum plants and are exposed to benzene are at high risk for leukemias. They found that in that population as well. Bone marrow hypoplasia. There's many disorders that cause that. The myelodysplastic syndromes, for one. These disorders, they notice in that population, they have a higher incidence of leukemias. Genetics, patients with Down syndrome, things like that are at higher risk. They've noticed identical twins are at higher risk. If one gets it, they're going to be knowing that the other one will probably have it too. So there is a genetic link there. Immunological factors such as autoimmune disease like Crohn's disease and things like that can certainly make people at higher risk for leukemias and lymphomas. And then interactions. It's just a host and environmental factors. Say you may have a population of people that works in petroleum plants, and some can work there and never get the disease, and then others are more susceptible to it. So, or work around radiation or something like that can work around it for long periods of time, and others they cannot. These are the causes of risk. And basically, there are two big types. There's acute and leukemias and chronic leukemias. Under that, we'll go over some types of those. There's many subtypes underneath these acute types and chronic types as well that we won't go over. The AML is the acute myelogenous leukemia, and the ALL is acute lymphocytic leukemia, and it matters on which white cell it's coming from, okay? That's usually a sudden onset with a very short duration, These patients are very sick on presentation. They know something is wrong. They're going to the hospital really quick because they're running. They're very sick, ill people. And then there's the chronic myelogenous leukemias, and then chronic lymphocytic leukemias. There's just a slower onset. It can persist for years. Possibly they could have it for years without any signs and symptoms. So they're not as sick, especially upon presentation. As this disease and chronic disease goes on, they can become sicker. It goes through stages, and they get sicker and sicker. But most certainly for years, they can certainly have enough mature white blood cells in their system where they're not as sick as the other patients and can go undetected even. So for acute myelogenous leukemia, this is just an uncontrolled proliferation of the myeloblasts, or the precursors of your granulocytes, is where this one is coming from. Again, it overcrowds other cells in your body. So, all that same thing matters. They're going to have fewer mature white blood cells, so they're not going to be fighting off infections. They may have some low-grade fevers, a lot of colds. They will have petechiae from thrombocytopenia, and bruising. Can be very anorexic, these folks with this acute myelogenous leukemia. Now, it's mostly in adults where they find that about 85% have acute myelogenous leukemia. Kids can get it. Lesser amount, about 15% of the population can be children. The onset can be between 15 to 39 years, and it accounts for about 25% of all leukemias. With acute lymphocytic leukemia, there is an increased production of the leukocytes. So there's a great proliferation of the B cell lymphoblast. That's a very immature cell in this lymphocytic leukemia. Its higher prevalence is in children and lower in adults, about 10% in adults. But with this, they do test them for a chromosome called the Philadelphia chromosome with ALL. They have found that if folks who have ALL have this Philadelphia chromosome, and not all do, it is a very high precursor or predictor of getting chronic myelogenous leukemia. So that's something they'll be looking at. Now, with this leukemia, if the child presents less than 1 year with it or greater than 10 years, they have a poor prognosis. Or if their white blood cell count is less than 50,000 or 10% leukocyte cells in the marrow, there's a poor prognosis. So most definitely they're all sick if this is an acute type, but these have much higher prognosis in the population. With chronic myelogenous leukemia, the major feature in this, again, is that Philadelphia chromosome, and is 20% of the adult base can get these leukemias. Typically, it's over 50 years of age. There are three major phases, like I said, in this chronic myelogenous leukemia. First phase would be the chronic phase, and like I said, it's a very slow progressing course. They'll have mild symptoms. They respond to standard treatment at this if they do find it and elect to have it. Bone marrow has usually less than 10% blast cells, so they've got quite a few still circulating mature cells. Then it moves on to the accelerated phase. And that phase features a spleen enlargement, and it's very progressive at this phase. They will start having maybe intermittent fevers, night sweats. They'll have unexplained weight loss. At this point, they'll have 10 to 30% blast cells, so they're getting very much sicker. This phase can last between 6 to 12 months. Then that last blast phase, that transforms into a very aggressive acute leukemia at this time. It's more than 30% of their blast cells. So acute leukemias can go into chronic, and then chronic, of course, it stages back into more of an acute at that blast phase. With chronic lymphocytic leukemias, the most common type of chronic leukemia, onset again is usually after 50 years of age. Average survival ranges for these patients are usually from about 19 months, and it can last, and advances to the disease can last up to 10 years for these patients. So. We want to get a good history when we have patients who are being ruling out leukemias, what type of leukemias. So as a nurse, we're going to be looking for any links to exposure to risk factors they may have had in the past with radiation or environmental issues, genetic factors. We're going to be looking at that. Changes to the immune system. Are they having more colds, more flus, pneumonias? If they had fever in the past 6 months, say. With bleeding tendencies, we're going to be looking for bruising, asking if they've had any nosebleeds, bleeding gums, this kind of a thing, or any changes in like menstrual flow. The menstrual flow tends to get heavier with leukemia and last longer. Weakness and fatigue with anemia, crowding out those red blood cells, and activity tolerance with O2, the lack of O2 because of anemia and fatigue. The clinical manifestations can come from a lot of different areas. It can be cardiovascular. And what you'll see is tachycardia, usually because of the lack of oxygen from the anemia. They will have some hypotension, palpitations, and murmurs. With respiratory, you'll see them have dyspnea, especially on exertion. They're fatigued, very short of breath because of those decreased RBCs. With their skin, with the anemia, they'll have pallor. Their skin can be cool to the touch. Because of the inability to fight off infections, you very likely can see infected lesions. With the bleeding, petechiae, and ecchymosis, especially without trauma. With GI, you're going to be looking for decreased appetite, decreased bowel sounds, and constipation. Most definitely, they can get nosebleeds and the tendency to do that as well. With CNS, you're going to be looking at these patients with headaches, decreased alertness, some cranial nerve alterations. They can even have something as profound as coma and seizures. And you'll see behavior changes in children with CNS alterations. With renal, you can see hematuria there. You can see in neuro some fatigue and headaches and fever, and musculoskeletal bone pain and joint swelling. And you'll also see some lymph node enlargements with these patients. With psychosocial, these patients are going to be very anxious. Anyone with a cancer diagnosis is very scary, but to know that they're going to have prolonged therapies and very lengthy and repeated hospitalizations is going to be very scary and cause a lot of anxiety, not only them, but their family and the people who love them. So for diagnostics, we're going to be looking at the CBC, at that hemoglobin, hematocrit, and platelets. We're going to be looking at the WBCs, on whether they're low, normal, high, and that could be any of those. Just because your WBCs are high, many of those cells can be blast cells, so they're not mature white blood cells. With this, kids may have to have a lumbar puncture. We want to be teaching about that procedure to the family, about what's going to go on into the child. We also going to be looking at chromosome analysis, like at the Philadelphia chromosome. We're going to be looking at MRIs and CTs for organ and lymph node involvement, loss of bone, mineral, and density in the bone as well. So AML can be treated with chemotherapeutic agents. With the treatment can be done in 3 stages. With the induction stage, that's a very intense treatment that can consist of a combo of chemo. Also, it can be they can have some radiation as well. So the goal here is for rapid, complete remission in this induction phase. It's quite intense. These are the drugs here that can be used. But many times you will see the 7+3 regimen for this induction phase. The cysteine is used continuously times 7 days. And then they will add daunorubicin for the first 3 days of this 7 days periodic treatments over that 3 days. So with the cysteine, it's an anti-metabolite. You need to know that you're probably going to be increasing your fluids. They need to be an intake of 2 to 3 liters per day, because you don't want the anti-metabolites to just sit in the body. You want for it to flush those out as they're doing their job. And then daunorubicin, it definitely can cause some red-tinged urine. Now, some of that is going to be, with this type of aggressive treatment, you're going to see a little red-tinged urine. It's usually caused from a little bit of hemorrhage around the inner lining of the bladder. Of course, if it got to be hemorrhagic, they would have to do something about that. But with a little red-tinged urine, it's usually considered to be part of the course. It's just the risk versus the benefit kind of a thing. The thing about it is, this can cause severe neutropenia, and many times the patients have a prolonged hospital stay on neutropenic precautions. And then there's the maintenance phase. The maintenance phase, I think I needed to go back over on another slide. The maintenance phase can be prescribed for months to years after they have successful induction and consolidation of those therapy. So the drugs are milder, and they're usually given PO. It's not unusual to see it given up to 2 to 5 years. Not all types of leukemia respond to this maintenance phase. And then some people ought not to have it, because some studies say that the staying on it with the ongoing side effects may be worse than the other. Depends on what shape the patient's in, and many factors goes along in deciding that decision making. CML treatment, drug therapy, you can use Gleevec, which is most effective on the Philadelphia chromosome, but it's certainly a first line of treatment for CML patients. The second line of treatment would be Spiracil, and the third line of treatment would be the interferon. The third line of treatment, the interferon, has many more side effects, and that's why they try to use the first and second line treatment if they can. If they can't tolerate those drugs, then they would have to go to the third, but or they can't. It's not helpful, or they say it's not helping the first and second line. With CLL, the drug therapy can be delayed until they see actual symptoms of the disease. So that's something they might see that they have some problems in their immature cells, but they're not opting to do anything. And that depends on age. It depends on many factors. But with standard chemo, they may be using chlorambucil with or without prednisone, which is also an antimetabolite, and then fludarabine, which is another drug, and rituximab. So those are also some drugs that you'll see for these chronic leukemias. Another treatment which has a lot of success is stem cell or bone marrow transplant. There's different types. There's the allogenic type, and that is when the patient is giving a bone marrow from a sibling or a matched unrelated donor. And then there's the autologous, which is using that patient's own bone marrow and they harvest that and then give it back to them when they give them massive doses of chemo, and they'll give their own bone marrow back. And then there's synergic, which is stem cells taken from identical siblings. The most preferred would be your autologous, if you can get away with it, because autologous, they would have graft versus host would be disease, which we're going to talk about later, would not be as prevalent in autologous. Allogenic, they're going to be looking at siblings because they're going to be the most likely the people that's going to be more like you as far as your genetic makeup, more so from your mother or your father, because your mother has one set and your father has the other, but your siblings, just like you, got both. So they're the most high on the list for allogenic type harvesting of their bone marrow to give back to the patient. This does present life-threatening complications, and because they're given such huge amounts of chemo when you do bone marrow transplants, that puts them at high risk. And again, graft versus is another one. Let's just go over the 5 phase. I'll get it out in a minute. In the transplantation part of this, there's 5 phases. There's the stem cell obtainment. So that's where they're going to go for those stem cells. They're going to get those that bone marrow from the patient. It can be bone marrow, or it could be cord blood harvesting, which they harvest cord blood and can do it that way. And then there's the conditioning regimen, which really serves 2 purposes. It's meant to wipe out the patient's own bone marrow, called myeloablation, and to give higher than normal doses of chemo and radiation to rid the cancer cells. This conditioning stage usually takes about 5 to 10 days, and then the patient will receive the stem cells. The day that the patient receives those stem cells is called T0. So, and that's a good figure on page 887 of your IGI, on figure 42.5, showing you that continuum of getting of these 5 stages or 5 phases. The transplantation day, again, is T0, and the stem cells are thawed and infused through a central catheter, sort of like a blood infusion. There's a key note here for the blood infusion. You would not use any kind of blood tubing, blood administration tubing, for this, because it would get caught up in the filter and they would get fewer cells. So you're just going to, these patients are going to get it directly into the vein and without any kind of filter. Now, the engraftment phase means that the transplanted cells have actually migrated through the blood, and um, it's causing it's surviving and growing both in the peripheral blood, first in the peripheral bloodstream cells, which takes about 8 to 12 days to do that, and then what really helps the patient is if they can survive and grow within the bone marrow, which takes about 12 to 28 days. Then they can start making normal cells there, and the patient can actually get a cure or be um, symptom-free, go into remission for many, many years, even a decade, with bone marrow transplant, and if it migrates and takes. We do want to check the patient's blood for genetic profiles or markers that is different from the patient's own. I think your book calls it chimerism. It's CHIMERISM. But nevertheless, we want to check for that because we want to look for graft versus host. And if we see these markers that's not their own, they may be susceptible to that. With post-transplantation, they're going to be in very stringent isolation. What they do is that they knock out the patient's own natural immunity almost completely, and then with they have to be on such isolation. So hand washing. If you had any kind of you thought, well, this is just allergies and my nose is running, you would always wear a mask around the patient. So you have to be, these patients are nurses there's a team of people that's very trained to be able to work around these types of patients. Now, there can be a failure to engraft when the body really looks at these cells that's been infused in them as a bad tissue, as a new tissue or foreign tissue. So it's attacking it constantly. So it's a failure to engraft because of that reason. And then there could be graft versus host disease, which does about the same thing. Now, for graft versus host disease, they can get cyclosporin, methotrexate, or a lot of other steroids that can help prevent that. Then there's the veno-occlusive disease, and that's just a blocking of your liver blood vessels by clotting and inflammation. It happens in about 20% of the people. It is very, very serious. It usually begins in the first 30 days after this transplantation. So pretty much there's nothing you can do I'll get it out in a minute. So there's nothing you can do for these vessels. These vessels will stay blocked. And at this time, it just gets to be a supportive type treatment that you're going to be doing. But now, the earlier you detect it, the more better prognosis they will have, at least a chance of survival. It is crucial to do daily weights and assess for fluid retention, which can be an indicator of this. Measure abdominal girth is another predictor for changes or any hepatometically. So if you can get these different symptoms as early as possible, there may be a chance with a very aggressive fluid management, but very high prognosis, very high mortality would be a prognosis for veno-occlusive disease.